I'd like to welcome you all back after morning tea. It seems like it was a long time since breakfast, so I hope you all feel replenished and comfortable and ready for the next session. I must say that when we started off and Simon showed the statistics and kind of tried to think about what our philosophy was and how we had this philosophy that was all these tools, as Simon said, and yet we've got this incredible disadvantaged or vulnerable populations that aren't accessing palliative care. It was a bit daunting to think about how we were going to kind of find a bridge, but over the course of the morning, exciting to hear the research and showing us the possibilities. And I think building on from that, this next session is going to talk some more about things that we can bring into our own practice, which shows us possibilities of how we can address this situation. I think services are judged by how well we look after the most vulnerable of our populations. And at the beginning of the day, I was thinking, gosh, we don't do very well. So I'm really pleased to be able to introduce you to Ria, although I'm sure that most of you know Ria extremely well. Ria and Vanessa, both from the Potter Hospice, going to talk about the services, some research they're doing around Maori palliative care, and also Vanessa talking about her role. Ria, as you'll know, has worked for many years in the public health sector, or the public sector actually. She has a wide experience and has been at Mary Potter as CEO for some 6 years. And I'm sure, actually, Ria, you need no introduction to this group. Vanessa, I'm pleased to say, is somebody who's reversed the trend lately, and she's come back from Australia to New Zealand, recently been joined Mary Potter, and really it's more about hearing from them than me, so I will move on and let them do their thing.
Thank you, Alison. Tēnā rā koutou katoa. I'm not sure that we're going to be talking about new research as such, but one of the context really for looking at the issue of the role of Māori support is as much thinking about the whole issue of how we address the challenge that was put to the palliative care sector through the palliative care strategy around creating better access or lowering the barriers to access for palliative care, and particularly for hospice care. What we'll cover is essentially 2006 to 2011. It's just coincidental, that is the time when I was appointed at 2006, but it's one of the key challenges that I was appointed, at the time I was appointed, was one of the key challenges presented to me. The focus of our role, the focus of looking at the role of Māori support has been really around removing barriers to access. And some of the two key tools that we've used for that has been the development of the Māori Service Plan and the Māori Liaison Role. Now, the Māori Liaison Role is not unique. And certainly there were some hospices, Te Omanga for example, that had a Māori liaison role in place well before we did. Neither is the concept of a Māori service plan unique, and it certainly was raised as a particular approach in the palliative care strategy itself. And then taking you through that to our current approach in 2012, but more importantly, just looking at the context of what we saw happening for our patients and whānau as a result of this work. So we haven't quite worked out our signals yet. To do a little.
You can do it there.
Oh, I can. Yes, okay. It's all right. It's okay, Vanessa? It's all cool. It's just that I haven't practiced, be warned. So in 2006, the population data for the Capital Coast District Health Board Māori were 10% of the population, 27,566. And Pacific, and I put Pacific there too because one of the issues that constantly comes up when we're looking at these issues from staff and from others is, well, yes, but what about the Pacific? What about the... And my personal view has always been that if we can work and approach the key issues around Māori access, we are actually on that whole pathway of addressing the issues for access for for ethnic minorities as a whole and all our communities. But so Pacific, 19,761, 7% of the population. In 2012, we are looking at the projected Statistics New Zealand figures, and I say that quite deliberately because, of course, the census was cancelled as part of the flow-on effects from the Christchurch earthquake. I think there is, in fact, a whole area of discussion, debate that needs to take place around when we start looking at smaller populations within the larger population and around the statistical applications that are appropriate and relevant. I might come back to that. The Palliative Care Strategy, 2001, really had said quite clearly that there was a view that Māori and Pacifica were not accessing hospice services, were not accessing palliative care services. One of the key difficulties was that there was hardly any data. In fact, in the Palliative Care Strategy, there's one chart which looks at where people die. It's in the appendix, and it does show quite clearly that Māori were more likely to die at home than non-Māori, and Pacifica were even more so likely to die at home than non-Māori. So what we were facing was actually a dearth of information, a view and belief that Māori were not accessing services and others, but not a lot of evidence sitting in behind that. And one of the things that I started doing was talking to Māori health organisations, and because of my previous role in the Ministry of Health, I quite often got asked to speak at a wide range of different sorts of groups, wanting to think about what were some of the issues with regards to palliative care. And one of the key issues is that for our health services and our health workforce, the real Māori health workforce and Māori health services, the real preference was to work in what I would call the sunrise part of health. The sunrise sector, the preventative health, mothers and babies, mama and pepe, looking at the areas of how we prevent chronic illness, how we manage chronic illness, for example. The palliative care services, I would describe to them as the sunset part of health services. And I owe some thanks to Saskia Boyman, who is in the Ministry of Health, for this little analogy, because I saw her give it once and I thought, yes, that speaks. And it's something that I use when I'm talking to Māori audiences, because they understand it and can talk about the fact that, like a sunset, where it's on the edge of moving into the world of darkness, into the world of the unknown, and which is one of the reasons why wairua or the spirituality issues become more critical and more obvious. And one of the things I always say, but sunsets are just as beautiful as sunrises. And I think when we're talking to Māori audiences, I think this, for me, this is the way that I have found, just starting off with some of that context about why I would be working in this particular part of the health sector. So that kind of shifts it from that demographic, statistical, technical analysis, and yet, because I am in that area and trained in that area, I go back to it after my sunset. When I arrived at Mary Potter, the then quality manager, who happens to be our current quality manager, having returned from being absent from Mary Potter, had carried out an audit on our admissions. And what that demonstrated, it was an audit 3 months on all the admissions coming into Mary Potter Hospice. Service, not the IPU, the service. And 3% of all the new referrals or the new admissions were Māori, identified as Māori. I thought, ooh, wow. Yes, that is low. Is that 3 months? What our quality manager had put in place as a result of that, again, this was before I arrived, is the protocols that have been put out by the Ministry of Health, and in my former role I'd been involved in that whole project, so I was quite pleased to see that was there. And they're still available and they're still relevant, and I pick up on the comments that have been mentioned that there is quite a lot of work in Statistics New Zealand, etc., thinking about census question, thinking about this whole issue. It raises all sorts of emotional issues, and Statistics New Zealand will say that one of the key issues that is raised around census when they go out to run focus groups on that, the ethnicity question is the one that's likely to raise the issues. From a health point of view, health data, health sector is one of the few sectors that compares its data to the whole population. If you're talking about rates, if you're talking about percentages, if you're talking about anything, we look at our data and we compare it to the population. Hence the drive around the ethnicity data questions and having the consistent framework. Even though it'll raise those emotional issues in discussion, it is about making sure that we can compare like with like. And what I did find was that our data at that time was very reliant on a rather antiquated database that was also set up by our administrative support were the ones who put the data in. And a whole lot of errors that had crept in over the years that had multiplied over time. And so effectively what we had as an organisation was very poor data. We didn't know, we had very little information really about, to stand back and look and say, well, where are our patients coming from? We could say what the number was in a caseload in the year, taking our hand data, but our database data couldn't tell us what we needed to know and did not record ethnicity. So, one of the things that our quality manager did as part of this audit, as a consequence of this audit, was put in place the implementation of the ethnicity data protocols. So for me, in thinking about the role of Māori support and thinking about where and our service and where we were going, the whole issue of getting some good data, trying to work out if what we are doing is in fact making a difference. And that's really, at the end of the day, is why you want to focus on this area. Is it making a difference? If it's not making a difference, what else do we need to do? If it is making a difference, how do we expand on what we've done? Again, our first speakers talked about it's not just putting in place the protocol, it's actually also about staff training. staff understanding why it's important, and to ease what can become a little bit of a stressful issue. Certainly, some research had indicated that one of the main reasons why the questions weren't asked was because health professionals were afraid of the kind of response that they might get. They were afraid that people might feel insulted by the way, and there's always that possibility. But actually the training was to help people feel calm about asking the question and confident around asking it and recording it. There's the other key factor in our approach over that time period has also been the establishment of the Māori liaison position. There wasn't a position like that in the hospice when it started. We have Vanessa, who is here today with us, is our third Māori liaison. So I think it's quite important to note that this actually is not an easy role. This is actually very hard work for someone stepping into a largely Pākehā organisation. Well, it is largely Pākehā organisation. In fact, there's 2 Māori staff in the whole organisation, and we're standing here. We're sitting up here on the stage. That's not counting our 2 contracted catering and cleaning staff. You need to look at what kind of support you're putting in around that person, what kind of access that person has to the senior decision makers, how are they being supported in their work. And in the process of doing that, we established Te Pau Tautoko, which is our advisory support group, Māori advisory support group. Now, some of the dynamics here, and I was interested in some of the issues around how you might set up different sorts of communications that was discussed from our previous speakers. But one of the things, for example, is as a charitable organisation and a voluntary organisation, the issue of how you ask people to give freely of their time when this is a valued resource. And the kind of approach that was done in actually just asking the individual members of our Te Pau Tautoko whether they would be prepared to be that support group was quite an important one. And what they appreciated was the fact that it wasn't just the Māori liaison person asking them this, that I was there as CE asking. But that is absolutely critical because we don't have the staff within the hospice to provide that support. And their role, as they see it, is supporting the implementation of the Māori service plan and supporting the Māori liaison position. The secondary role is supporting the organisation. So it's an interesting little set of dynamics, but that's how we've set that up after the discussion. What I want to just go about, we somewhere on one of those slides I talked about a chart audit. The research director who did come and is quite well known in the hospice sector, Dr. Beth Johnson-Taylor, when I talked to her the problem about our data, we were planning on going to Palcare on the 1st of January 2009, and I knew that we would be able to get good data from our electronic patient management system. When I went to her and said, I've got no idea what percentage of patients am I, I've got no idea around age groups, I've got no idea around gender, I've got no idea around diagnosis. Yes, I've got a bunch of statistics that somehow we'd continue to supply as part of our contractual agreement, but I knew the database was not robust. And so I couldn't be relied on. So in looking at this, we're able to say is where our total caseload in a year, so total number of patients in the service over a year. And 2010-11 was the first year it just dropped slightly. So it'll be interesting to see what happens, because we believe it'll be up again next year. And so what she did was, for 2006, 2007 and 2008, she set out a project of a chart audit, simply to look at our paper charts. We looked at 3 years of discharge data, so from January to December, year after year. So this was what came through in the chart audit. Now, I haven't put the Pākehā or the New Zealand European in there. I've just put this as just the Māori data of those who were discharged, and it's just important to remember, of course, that when we talk about discharge, we're actually talking about mostly those are the patients who have died. 1 or 2 do get discharged to another area, but they are the patients who have died. So those are the records of those patients who have died. And we put together a small volunteer group, small piece of research. It was quite a process, training the researchers as well. But the 3% audit on access was an indication, was not far off. So that 3% audit was done in 2006. The chart audit on discharged patients showed 4.5% Māori out of the total number for that year. 6.3 in 2007 and 6.8 in 2008. We then have been, and during that time, of course, we were implementing, those 3 years, we were implementing the Māori Service Plan and Māori Liaison Position. The first Māori Liaison Position started January in 2007. So now this is another cut and another look at using our admission data from Palcare, starting with 09. And now this is not a January to December year. This is a financial year, July to June, and it is based on the admission data, not the discharge data. So there are slight differences here, which is why you need to make sure you differentiate, but at least that gives us an indication of where we're heading. The blue lines are the Māori percentage of those who admitted in that financial year. This is based on our quarterly data, so it's looking at the total. The June-December 2011 is because that's just 2 months, 2 quarters, 6 months of the year. Need to put our most recent previous 2 quarters in. What you can see is what we were starting to observe as we were monitoring our quarterly data, is that our Māori data was at least beginning to look like our population data. So if our last quarter data, the quarter to December, was actually 11%, 11.1%, but of course when it sits just under 10% when you're looking at the whole. The other interesting thing is that the work that we also want to do is looking at our Pacifica, Asian and other. Now, just coming back to that issue around how important it is for staff to be trained, if you look at 2010 and 11, you'll see that purple line is quite high. And our Director of Research at that time said, "Woo, This is more likely to be other and not recorded and whatever. So that's when we started another bout of training. We did a lot of intensive training, and interestingly, as you can see, in June, December, the 6 months to December 11, the other category starts to drop. So there's something here around the training and needing to keep this going, to let our staff know how important that is. The other issue, I think, is here is our Palcare data is based on admission. So the variable of ethnicity data is linked to admission data. It's not linked to any other variable. So when I got a question from the other research project, and which all hospices would have got, asking for the ethnicity data and asking it for it by age, gender, age groups, 5-year age groups, diagnosis, place of death. I thought, oops, that's another whole research project. Because effectively we're going to need to go in and actually analyse it by patient number, because although I've raised this with our Palcare administrators, we're not able to just dip into our session and pull out Māori by age group, or Māori by gender, or Māori by diagnosis. We're going to have to go in month by month and look at each individual patient and go into the patient record. Okay, our Māori service plan, based on the 3 treaty principles that are outlined in He Korowai Oranga: partnership, participation, protection. So the concept of partnership there being how you partner with the Māori communities, iwi, Māori organisations, Māori health providers, Māori sections of mainstream health providers, Māori, other Māori groups. Participation. Now this is I think is the next big challenge for us, and we've got some ideas that we can start with, but the participation around workforce and workforce development, participation in the board level, how you use advisory support groups, volunteers. Protection, of course, just the principle around here. There's 2 concepts to this one, and one is the protection of some of the cultural values and perspectives and views, and some of the issues from our earlier speakers from Waikato, thinking about how you might build in the protection of those kinds of concepts around death and dying. The second issue is really around access, protection of, not around access, it's around protection of ensuring that the same level of care is going to be provided regardless of the ethnicity. So it means that in our case, and palliative care, from my perspective anyway, is looking at access and then the quality of care. Challenges, Māori health workforce development. I'm hoping that we can refocus on this again for the next couple of years. One of the things is around how we work with the setting up and developing Māori community health workers in our community, how we look at Māori staff within our own organisations, Māori volunteers. So it's not just about how we as a hospice is, but how our community and how our sector and how we're building that development. Funding, because the funding has been a nightmare. And each time I've gone back to the board around the reappointment of another Māori liaison. And it's a challenge, and it's become more of a challenge in this current environment. Because we don't have access to targeted funding. It is, in fact, funding that needs to be funded from our community funding. Community supported. thinking about how you maintain sustainable relationship, how you sustain the relationship and maintain it over time so it's not about the individual to individual, it's about the relationship of the organisation to the organisation or to the group, the rōpū or the iwi. And we've done a number of things in this area. Research identifying the issues. So we've about to publish the work of our small investigation, very small qualitative focus group, hui, looking at Māori experiences of hospice. And I know it's just being peer reviewed. A little bit frustrating for me because it's taken a few years for it to get to this point of actually being written and drafted up. And it's kind of exciting to see the range of research that's currently going on around the country, a whole range. So in 2007, 2008, the first Māori liaison position went about building networks. And it's sometimes hard to look at and describe what those outputs are that relate to network building. And it's got to be seen over time. Established Te Pou Tautoko and started the meetings with Te Pou Tautoko. And one of the first things that we put through Te Pou Tautoko was our tikanga guidelines. Now, tikanga guidelines, again, developed originally by Waitemata DHB, picked up by a number of other DHBs, and we picked up certainly a version from the Capital Coast DHB. We looked at it, modified it slightly. We also then looked at one of the PHOs who were more focused on the community side of the service rather than the institutional side, which was, and put those together. But we started an annual training day at one of the local marae, depending on, we've visited 2-3 marae, but the organisation, and we made it a one-day course, the organisation required for a 24/7 service to actually get a group of staff for a whole day is quite enormous. And so a whole day commitment for a year was a significant commitment. The first year we ran it 3 times, even though it was intended to be an annual because the demand was so high. We've run it annually since then. We supplemented that with waiata sessions. We supplemented it with bringing in our external speakers from time to time. We've built it into a number of our courses that we run, looking at Māori perspectives and views on a range of elements in the courses. So it doesn't stand on its own. But the training day at the marae, what surprised me, stunned me a little actually, was the number of staff that had never been to a marae before. So that whole experience, just that in itself, was enough to kind of jolt thinking about different patterns and ways of thinking of the world. And it's actually not that surprising when you think about the number of number of our staff that actually are from overseas. So the second Māori liaison who started, and there was a gap of 6 months here, and if you think about this time period, this was when the global economic crisis crunch hit. And for the first time in a long time, Potter Hospice ended the year with a significant financial deficit. The board approval for this was based on a 1-year contract, 18-month contract. So the second Māori liaison went about looking at internal training and supporting the waiata karakia pōwhiri. And one of the really interesting approaches that she used was, particularly with our Kapiti community team, was with the building of the relationships with the Kapiti kaumātua who was supporting the Māori health provider, right across the road from our Kapiti office, and holding sessions once every 3 months for half a day. They would come in and it was a whakawhanaungatanga. So they would talk about themselves, the history of that area, their marae, how it related, and then the team would talk about them and their work and their mahi so that they could understand issues around palliative care. So it was a sharing type, rather than a lecture approach, which is the kind of approach we tend to use. And we've still plan to build on that particular set of work and look at how we sustain those relationships and how we bring those into the very different parts of our communities in our region. Our second Māori liaison did quite a bit around supporting the research capacity. So for when it came to doing our research on whānau, it was the Māori liaison that did some of the initial approaches to whānau as to whether they'd be prepared, help set up with support of Te Pou Tautoko, the kind of setting and framework. We developed that research with Te Rangahau Hauora o Eru Pōmari, the Eru Pōmari Research Centre, which was a key critical component as well, given that our director of research was American. And of course, then at the end of 2010, that's when we had a gap, another gap. This Māori liaison, Pui Wahine Tabo, left in January 2010, and so it was another 8-10 months before the appointment of another. And in that time, I again had to go back to the board and argue and debate the case for this position. So in 2010, in 2011, we were really pleased to welcome Vanessa Eldridge, Ngāti Kahungunu, on board. So kia ora, ka te mihi ki a koe, Vanessa, and it's your part of the session.
Kia ora, tēnā koe ria. Thanks so much for setting the scene and the context for my portion of our presentation today, which by far I'm sure is going to be the easier one. I'd like to start out today by telling you a little bit about how I tackled my new role when I joined Potter Hospice in December 2011, and what the role of support for this Māori in palliative care was. I set about learning what had been done in the past, by who and how effective that was. I was heartened to find a solid foundation had been laid, the budget secured, and a plan was in place. I found the previous workers had brought their own strengths to the role, and it was okay for me to do that too. I could create my own shoes, so to speak. I had a crash course in palliative care, the health system, and all the existing and potential networks that might ensue. In January, I learned there was a Tikanga Māori Day to be held in February at Takupawahia Marae, and I was supposed to be organising it. I paddled through and found that this was a valuable event to complete. Not only did it give cultural safety training to our staff, but it was a gauge for me to see our staff's exposure to Te Ao Māori. It allowed me to work with local iwi. I met our Māori board member, Ani Waka, and I was supported by members of our Māori advisory group, Te Pou Tautoko. And I grew my own understanding of Māori health policy and the Treaty of Waitangi with my fellow presenter, John Whanga, from Kaipuke Consulting. When I first looked at our Māori service plan, it was a little daunting. When Ria said to me in the interview, "We do want someone that can walk on water," that was a little daunting. At my first meeting with our Māori advisory group, Ria talked about a future presentation that I'd be making to the hospice board, and that was a little daunting too. Although one of the kaumātua there, Matuakarewa, Arthur, had only known me for 45 minutes, he said, "Oh, hey, I think our girl might need a bit of a korowai for that hui. I'll gladly go with her, and what about you, Kahu?" And I was so grateful that he said that. One was, I was already their girl, and number two, he was offering really generous support. And later, I thought about that, and about the korowai that Matua offered that day, and who else was in it. Since then, I've found that my korowai is made up of Ria, our decisive leader, that shares her rich background and shares her strategies for the future with me. Jane McGeorge, who I report to directly. Jane is a supportive ear, a provider of tools, and a navigator to help me hatch my plans. Te Pau Tautoko, our Māori advisory group of kaumātua and local Māori health providers. I value their guidance and their advice greatly, particularly given my many years living abroad. And our colleagues as well, for their research, for their education, for communications, and for their interest in what I do. These people make up my korowai, and I feel really well supported in my mahi. Once I'd figured out what my mahi was and who my korowai was, I needed to get together a game plan. The Māori Service Plan and all of my reporting aligns with the Treaty of Waitangi principles. I've made things simple for myself today, and I've aligned our presentation in the same way. The Māori public participated with hospice at a health festival held in April. This event was called Creek Fest. It's held in Cannons Creek in Porirua. Creek Fest is a health festival with sport, music, healthy kai. Thousands of people come to this event from Kapiti through to Wellington. It's held in a very socially and economically challenged area. Our staff and volunteers made the tent for a day. We received several hundred visitors and offered a kete as a prize. We also have several Māori volunteers that work in our retail stores, and they help provide our Māori face to the public. On the 27th of June, we held the official open welcome for our Porirua base. This event anchored our relationship with the local iwi, and we welcomed the community to our building for the first time. We were aware that the Porirua site held some significance, historical significance for Ngāti Tō Rangatira. We're aware that our Porirua, we conducted some research and found that it was the last fortified power site for that iwi, that there had been mass baptisms that had taken place there. We designed 2 large historical boards that are on display at the Porirua base, and we revealed those boards at the opening and presented canvases of them to the iwi. The chair of the Runanga was most pleased, as were the other kaumātua and nannies that were there. For Māori health providers, I've spoken at iwi cancer support groups. Right now I'm working with other local Māori health providers on understanding cancer workshops. The workshops are aimed at those working in Māori health so they can have a better understanding of the services available to Māori and know more about Māori whānau ora in order to improve the care that they are able to give to Māori people. The programs include elements of Māori sharing their own experiences, and that's young and old, Māori presenters and Māori practitioners, and where possible, rongo Māori practitioners will be there too. I've been asked to talk about the practicalities of what takes place when somebody passes away at home, or what we do when somebody passes away at the hospice. I've been asked to take along a funeral director because the people there want to have a Q&A session. Naturally, the clinical sessions of what is cancer, health promotion and cancer prevention will still be included, and we'll be offering a follow-up hikoi, a tour, where people can visit the Blood and Cancer Centre at Wellington Hospital, the Hospice and the Cancer Society. This gives good support to Māori whānau via those caring for them and contributes to their own korowai. Thank you. Times are tough and money's tight. There is a need to do more with less, and this gives rise for creativity and collaboration. Forming alliances, seeking input and wide inclusion is always just the Māori way. Here are a few small fruits of some liaison that I've managed to notice in the brief time that I've been with the hospice. We hope we might grow our Māori workforce. I've met a nursing student at a cancer support group and found that she wants to work in community nursing, possibly palliative care. We're investigating how we might be able to get some funding to take on a Māori nurse graduate. I met a volunteer who was a student at the Wānanga of Aotearoa. She's half Samoan, half Māori, and is studying a degree in social work and biculturalism in practice. She asked if she could do her first 20-day placement with us, and so we're investigating how we're going to be able to accommodate her too. We might get some free education. Through our participation with the Wānanga, our staff have been invited to attend some of their Māori Language Week celebrations next week. An external education provider is asked if they can use our facilities at Porirua. Their koha for our facilities might be free registration at what they're offering. And we might get some free stuff. I'm meeting with a Māori liaison person at Kapiti Coast District Council next week to get some of their wonderful matariki calendars for our staff and patients and volunteers. But most of all, I enjoy hearing about the work that she does with her 3 local iwi there. And it's important to know our people and our staff and our volunteers, what networks we have access to and how to harness and utilise those, but in an appropriate way. These opportunities give support to Māori and contributes to their korowai too. Sorry. Much of my effort in the past 6 months has been towards partnership and participation. Protection is a principle that I will focus on with the rest of our colleagues more moving forwards. I feel this one entails the most internal liaison for me within the hospice, ensuring equity for Māori stretches across all of the hospital's operations and needs wide cooperation. Ria and Jane continue their work at strategic levels too. Here we need to ensure a Māori view is sought, that the Māori view is considered, and that outcomes are positive for Māori, and our communications reflect that. To this end, there are several projects I'd like to start working on, involving the usage of reo and tailoring some of our activities so that more comforting and more familiar to Māori. Thank you. From time to time, our palliative care coordinators will send me a referral to visit a whānau. The needs for engagement and assistance from me can vary greatly. We Māori are a very diverse bunch. And I just want to tell you a little bit briefly about 2 whānau that I've worked with. I've recently worked with a patient called George, a Pākehā gentleman, and his Māori wife. And his Māori wife Mary. I've been meeting with Mary for 2 or 3 months. I've attended whānau huis at the inpatient unit. Sometimes I've given Mary's lift to be able to go and visit her husband in the hospital. On a Wednesday afternoon, we stop and buy a lotto ticket on the way because that's what she needs to do. We had some photos taken with Mary and George, and we were able to give those back to her. We were hoping to use those for some communication purposes. She loved them. Mary will text me from time to time. Some of our talking has been around how she would keep everyone happy and included for the period leading up to George's death and the funeral. Mary has a more traditional tūhoi background. Her urban Māori children have their own views, and her husband is of Scottish Catholic descent. Mary talked of the social issues and challenges throughout their marriage. George passed away recently, and when I saw him last, he was laid out in the lounge room. Mary had fashioned a korowai for his coffin, with tūhoi white feathers dear to her heart, near the top. It was lined with tartan. Around his neck, George wore a pounamu from his children, a crucifix from his family, and a wedding ring for Mary. I will call Mary this week and see how she's travelling. In contrast, one of our PCCs recently received a phone call from the ambulance service. The whānau of a new patient to our service had called them, concerned about their mother's breathing. The ambulance service were at the home. I attended the home within 30 minutes with our PCC and found the patient was in the process of dying. In this instance, I could interpret and reinforce clinical information from the PCCs. I could talk to whānau over the phone and explain what was happening. I could make cups of teas for the descending whānau that were arriving. I could book a night nurse. I washed the dishes. I occupied the nannies. I found out that they knew some of my aunties too. I looked after a baby. That patient passed away within 3 hours of us meeting her, and I don't believe they'll need anything further than the usual follow-up from the hospice. In my experience, people like Māori people like to support our own. We find each other, we find comfort and support in each other. Through research, talking with whānau and with our PCCs, it is evident to me that our whānau are not stupid and want things explained to them in plain English. We are very grateful when people take the time to tend to, talk and touch them. We are humble people, may not kick up a fuss and may suffer quietly. Like everyone, our people want to be heard and have their questions answered without condescension. They may be conscious of being the only brown face in the room. They may be more receptive and willing to talk to another brown face. We may have complex underlying social issues and whānau structures. We may have small or great cultural needs, and that can't be decided by an assessment of our skin tone or how we speak. As workers, we can give the most amount of support if we take time. That is the great support for Māori. Thank you. Yes, we'll do that.
Te aroha, te whakapono, me te rangi Māori e tātou tātou e. Kia ora koutou. Kia ora koutou.
Wow. That was amazing, and I must say that for the only true Māori than Mary Potter Hospice, you two certainly pack a punch above your weight, I would say. The only thing of concern to me was the qualification that you have to get a job there, which is the walking on water. So, look, we're running we're just tight on time, so maybe just if there is a question or two, and then maybe following up at lunchtime with Ria and Vanessa. Any questions from the floor? You've left them speechless. Right, well, thank you both very much for that wonderful presentation on the service at Mary Potter Hospice. I'm sure there's a lot for us all to take away from that. Thank you.